How's everybody doing? Dr. Gillard here once again, and it's time for our Thursday marathon lecture. A lot of slides today. Try to get over a little bit over 100. It's supposed to be a 3-unit lecture. We'll see. We'll see where we get. So, diseases of the esophagus and stomach. We're still talking about. This is Thursday. This is week number 3. This is not week number 1. Have to fix that. And yeah, here we go. It is Thursday. Off we go. All right, so we left off, we were talking about gastroesophageal reflux disease. Remember we looked, this was a picture of what erosive esophagitis looks like. And I don't have to review that. I think that's pretty straightforward. But we left off talking about what do you do about it if you have GERD, super common problem. What do you do about it if you have it? Well, acid suppression therapy is the gold standard. And that mainly entails the use of proton pump inhibitors. H2 blockers, prokinetics are also used. Kind of got a cancer scare on this one, so we'll get into. And then on top of this, you have to do some lifestyle and dietary changes to combat GERD. Otherwise, you risk the chance of getting a precancerous condition called the Barrett's esophagus. Let's start with what kind of lifestyle changes you can do. Don't go to bed until at least 3 or 4 hours after a meal, especially if it's a big meal. You should maybe even do 6 hours if you struggle with GERD, because you cannot go to bed with a full stomach, or if your sphincter doesn't hold the fluid inside the stomach, if it's all filled up, it's going to squirt into the esophagus really easily. So that's kind of the rule of thumb. Don't go into the bed until 3 or 4 hours after a meal. If you do have a big meal, but if you have to eat late at 8 o'clock and you have to go to bed at 10, well, then you need to sleep in a recliner. If you sleep in a recliner, then gravity will help hold the fluid in your stomach and without burping up into your esophagus. And then don't overeat. If you're going to have a gigantic meal, let it be a late lunch. All depends how bad your GERD is. And then everybody repeat after me. Right is wrong. Let's say it. Right is wrong. Okay, good. Yeti, are you saying it? Right is wrong. Okay, you do not want to sleep on your right side if you have GERD. We'll look at that, how that works in a second. Especially if you have to go to bed with a fairly full stomach. So avoid irritating foods as well, especially close to before bedtime. Alcohol is a depressant. It relaxes all your muscles, including your already wimpy lower esophageal sphincter. Remember, that's the sphincter that holds the acid in your stomach and doesn't allow it to bubble up into your esophagus, which is not designed to handle that type of acidic environment. Spicy foods, caffeine, chocolate, fatty foods, which stimulate the production of more acid. High protein meals I could have added in there. Oh, I did. Super high, like fish is hard to eat. Tomato-based sauces, spaghetti, lasagna, things like that. Really tough, really acidic, really tough for people with GERD. More stuff. Stop smoking. Smoking irritates GERD as well. Sleep with your bed up at an incline. You can put some blocks. They make them for your bedposts where the headboard is. You can put that part of your bed at an incline. It's not nearly as effective as sleeping in a recliner, but sometimes that's all you need is just a little bit of elevation. Or you can use a foam instead of sleeping in a recliner. What if you're on vacation and you don't have a recliner? Then you can use a foam inflatable wedge to kind of prop up your trunk. I'll show you a picture in a minute. And yeah, if you have overweight, especially if it's abdominal weight, you can lose that weight. That'll decrease the pressure that's put on your stomach, and it'll decrease the decrease the amount of acid that is pushed up into the stomach. So this is what I took to. We went to Hawaii last summer, and my GERD is pretty bad. So I was worried about, oh man, we're gonna have to eat fairly late. How am I gonna do it? I don't have my recliner to sleep in. And this thing worked fantastic. And it's not a huge wedge, right? That's not even, that's about 30-degree wedge. And it's blow up super light, and that was a real lifesaver for when we went out and had a margarita or two and ate food. Otherwise, I would have been in big trouble. Right? Here's even a little higher. It's probably about a 40-degree, kind of a soft pillow that you can use. Because how's the acid? Let's see, did I turn on my markers? I did. So here's your, just make a cartoon. If, let's see, if this is your stomach right here, and here's your esophagus going up to here. And so now we have your food. You ate a big meal. Here's all the chyme and the fluid and the mashed up food in your stomach. If you raise yourself up like this, it won't come in contact with the lower esophageal sphincter, right? Lower esophageal sphincter is loose on you. You don't want the GERD, but I mean, even if you eat a huge, gigantic meal like this, then you're going to have contact against that wimpy sphincter. You are going to have some reflux if you eat a gigantic meal. But the force of gravity, we have gravity, of course, pushing down. So that's going to discourage the GERD from climbing, getting out of there. But that's kind of the principle behind that. Okay, everybody good with that? So what about some other treatments? Over-the-counter meds. Tums are incredible for this. They greatly relieve. Remember, that was one of the tests to kind of anecdotally see if you have GERD. If you get really good relief by Tums, you probably do have it. So this works great. There's some other ones. The only one that ever worked for me is Tums. But you got to be careful. These are calcium carbonate, right? So if you're a stone former, if you're a calcium stone former, you can get stones from this because it gives you a good dose of calcium, right? So H2 blockers, these things never work for me. I mean, my wife, I had a young grandson who struggles with GERD. These things don't work for anybody in our family. They didn't work for me at all. Research shows they're about 50% effective, and some of those studies were the manufacturers of the H2 blockers, so that number is probably high. I'd probably say like 25%. They might be useful to mix in with a PPI, proton pump inhibitor, though, for nocturnal acid, as we'll see. But the good thing about them, there's a little bit of a ruckus, a little smoldering smoke that PPIs might be related to osteoporosis. So H2 blockers are definitely not related to osteoporosis at all. They seem to be much safer than the PPIs, although we just had redinitine recalled, which has been around for probably 40, 50 years. And now it's got what was it in there? NDMA is in there, which is a carcinogen, a powerful carcinogen. So I checked the website of the FDA today, and their recall, I thought maybe it was a small isolated problem. And no, they're completely recalled, all of them. They recommend you throw them away. The longer they sit on the shelf, the more the NDMA kind of bubbles up. So here's the players we have left. Tagamet, and these are over the counter now. They used to be, back in the day, these are only prescription. Pepcid AC, but now most are over the counter. The big one was Zantac, or ranitidine, and that was not, I could take that out. It's not a voluntary recall anymore. It's FDA recall now. It's FDA warning. Did I put it in here? I did. FDA requests removal of all ranitidine products, Zantacs, from the market. And that was published on April 1st of 2020. So yeah, that's a bombshell. Anyway, how does the H2? Here's the problem why they don't work. So it works by blocking histamine at the parietal cell. It binds to and blocks the binding of histamine. So it's kind of a blocker. And let's take a look at, there's our parietal cell. We're going to talk, actually I think I cut a lot of this out. I'm going to make you read on your own just to save time. There's so much pathology you have to get to. Can't be repeating your physiology classes and everything. But your H2 blocker goes right here, and it binds to the H2 receptor on the parietal cell. So when histamine, which is probably the most potent stimulator of the proton pump to generate hydrochloric acid, it can't block because the H2 blocker. But what's the problem with this setup? Well, what about gastrin? I mean, gastrin is released. And what about acetylcholine, which comes out of the enteric nervous system of the stomach? Vagus nerve feeds it. I mean, these aren't blocked at all with H2. So you're just kind of ramping down. Maybe at the best, maybe a third of the production is decreased in this. I think they're probably more of a placebo, honestly, than anything else. See a problem? Yeah, we just did it. They don't address the other two receptors, gastrin, acetylcholine. They also stimulate. So sympathetics and parasympathetics, they can all release acetylcholine. And yeah, so everything I said. The prokinetics is another drug that was hopeful that it worked. There's some research, but the problem is it causes cardiovascular disease. So the best ones were pulled off the market. But it's designed to decrease or increase the tone of the lower esophageal sphincter. Remember, that's the problem. The lower esophageal sphincter is too tight or too loose. It's wimpy. And so we're going to try to beef that sphincter up by the use of medications, but it has obviously widespread effects on the rest of the body. So that's not a good thing. And what else does it do? It also increases peristalsis of the... I'm trying to set my clock. That's what I'm doing so I know when to stop talking. It also increases peristalsis. Now, what in the heck does peristalsis have to do with GERD? What does that have to do with GERD? There we go. Well, if you get... Okay, here's the stomach. There's the esophagus. And if you get some, here's your meal sitting in your stomach. If you do get some regurgitation of acid, we'll just make it look like this. How do you get rid of it? Well, your peristalsis ramps up, right? You get a wave of peristalsis going down here, a secondary peristalsis, and it pushes that fluid back to where it belongs. So if you have a problem with peristalsis, like some of the motility disorders we looked at, you have a problem with GERD typically as well. And as I said, several of the best ones are banned, so that's not good. Proton pump inhibitors. So took quite a few slides out on this, but you do need to know about it because a lot of your patients are going to be on them. Maybe you or your family member will struggle with GERD, so common. So they're about 80% effective for symptom relief. So that's awesome. The problem with them, though, it can take 2 or 3 weeks for them to show an effect. So people get discouraged by that. So you should encourage, your patient can use over-the-counter Tums and things like that until these kick in. You can use them together. So the key PPIs, my favorite one was the Protonix, works really good for me. It's prescription. The Prilosec is over-the-counter, used to be prescription. And Prevacid is another one. I think that is over-the-counter now as well. So there's more, but those are the 3 that I might ask you. So those will show up on your patient intake forms. The problem is I took all this stuff out and went into the research, but there is kind of a little smoke about osteoporosis, the long-term use of PPIs. It seems that it does increase the chance for osteoporosis, 10 years down the line. If you have an incident of GERD and you use PPIs for 6 weeks or even 6 months, I seriously doubt you're going to have a problem with osteoporosis. Most of the studies showed the problem was with people taking who are on these PPIs for years and years and years. So certainly a 6-week course or so is not going to have any effect. You lay people watching, though, this is educational only. Talk to your primary healthcare physician before acting on any of this information, right? Just for educational purposes. Proton pump inhibitors, they are absorbed. They don't have to go into the bloodstream. They're absorbed right through the stomach wall, and then they're soaked up by parietal cells. Parietal cells is where where the hydrochloric acid comes from, right? And parietal cells, parietal glands really, parietal cells are in fundic glands or accentic glands. And we'll talk about those. But yeah, they produce hydrochloric acid, an intrinsic factor. So the PPI sinks into the stomach and it goes into the proton, or goes into the parietal cell, and then it gets inside the cytosol and it binds to carbonic anhydrase and stops that enzyme. That's a key enzyme in the formation of acid, right? You probably remember that from your physiology, right? That makes carbonic acid, which dissociates, and that's where the hydrogen ion comes from. And then if that ain't good enough for you, it actually binds to the hydrogen potassium ATPase, alias the proton pump, and it screws it up. We won't go into the mechanism. So it kind of double inhibits the release of acid. So that's probably why they're so effective. So you can't make acid. The trouble with PPIs, though, after a while, especially if you have a huge meal, your stomach will realize that, hey, proton pumps are working, but the meal is still not acidic enough. The stomach juiced that, so it's not enough to break down the proteins. The stomach will order the production of more proton pumps, but usually that's a couple hours away before that happens. So if you eat moderate meals and proton pump inhibitors, you usually do pretty good with this thing. And there's no problem with NDMA contamination like there is with ranitidine. Right? I like this kind of geeky stuff. So here is carbonic anhydrase, and the protonic, one of its functions is to soak into the parietal cell here, and it binds to carbonic anhydrase and neutralizes it, so it can't make its acid here, carbonic acid. Normally, carbonic acid dissociates into bicarbonate, which is spit out the back, and hydrogen ion, which is spit out into the lumen here, and that's going to bubble up to form acid. Chloride just follows like a puppy dog, follows the hydrogen ion. Okay, and then the other part of PPIs, they bind to the proton pump or sodium potassium pump itself and discombobulate that, and that's how they work. So pretty effective. Here's a classic study that was published back in the day in the New England Journal of Medicine, one of the most prestigious journals in the world, that and the Lancet from Europe. So it's an old study, but it's pretty good. It's still effective to this day. So these patients were involved in a study, I forget, like 500 of them or something, and they all had GERD, and they followed them for 12 months, and they were randomly given either a R2 blocker or H2 blocker, or a prokinetic by itself, or a H2 blocker and a prokinetic, or just a PPI, or a PPI and a prokinetic. The PPI and prokinetic did win the game, but the difference here didn't turn out to be statistically significant. It was close. It suggested that adding the prokinetic did better, so it was really close. But between 80 and 60, this was a significant difference. So the PPIs are head and shoulders above H2 blockers and above prokinetics. Clinically, that's found that to be true as well. Okay, let's see, most recent, what about the success of PPIs? About 13% of people with erosive esophagitis, they get no relief. So 87% success rate. People are pleased with PPIs. So that's a really good number. Those darn NERD patients, though, those NERD patients don't do good with anything. 45% of them didn't get any relief with PPIs. So it's really, being a nerd is not a good thing with regard to with regard to GERD symptoms. How come they're not 100% effective? They've went on to theorize that the proton inhibitors kind of peter out. You take proton pump inhibitors on an empty stomach in the morning, and the problem was they kind of peter out overnight, and some people do release nocturnal acid. And sorry, I had to turn my phone, was ringing there. And so they kind of peter out at night before you're scheduled to take them again. So some research has demonstrated that if you add an H2 blocker before bedtime, you get kind of a better relief. It kind of covers you during the nighttime. Or you could double the dose of PPIs, which what effect that has on osteoporosis. Probably people might get osteoporosis quicker, but there's no research on that. But so what's the theory? Why aren't they 100% effective, you think? Probably because of nocturnal acid, and they're wearing out at night. What about other causes of GERD-like symptoms? So what else can simulate GERD? That's an important slide. A lot of stars on this one. Well, medications. If you start antibiotics or some new type of medication, some medications are notorious for upsetting your stomach and your esophagus. So medication-induced gastritis, gastropathies, that's stomach upset, dyspepsia, or upset esophagus are common with medications. So one of the first things to ask, what kind of medications are you on? There are certain autoimmune diseases that I think I put them back in. I take them out and put them back in because they're rare, but they're two really important blistering diseases. Even though they're rare, I sometimes worry they'll be on boards. I only have a 45-minute lecture in dermatology, which is not nearly enough. Anyway, I promise I'm not going to digress today. So there's two autoimmune diseases. There's one called pemphigus vulgaris, which is quite deadly. The most common, though, is called bullous pemphigoid. And it's not as deadly anymore, but it can be quite disabling. It still can kill you. But it's weird because remember hemidesmosomes and desmosomes? Remember, hemidesmosomes hide in the basement, H and H. So those are the ones that connect to the basement or the basement membrane or the basal lamina. There's a protein in there that helps hook the cytoskeleton to kind of the rivet head or the plaque of the hemidesmosome. And that protein's called BP230. And for whatever reason, the body attacks nothing else except BP230. Really weird, but it rips the hemidesmosomes apart, and the inflammation causes the skin to bubble up. So, nasty blistering disease. Eosinophilic esophagitis, I just cut those slides out. Again, I want to get further and further. I probably have 3,000 slides for this class, and it's hard to figure out which ones to cut out. So, eosinophilic esophagitis can present with GERD-like symptoms. The only trouble, PPIs will have no effect on this because it's an inflammation of the esophagus secondary to inflammation that is eosinophilic or eosinophil heavy. And so it happens in about 0.06% of the population, so it's more common than Marfan's, but that's all I'm going to say about it. If you want to learn more about it, I do have a YouTube video on my site. Not this site that I'm putting all these up, but on my main cargeek.com page. It's like 130 videos up there, but you can find it. Anyway, heart disease. So heart disease can refer pain to the esophagus. And infection. Maybe you have an infection of the stomach. Maybe it's an HP infection, right? We'll learn about HP gastritis, non-atrophic gastritis, where HP irritates the antrum of the stomach, causes the relief, which stimulates G cells to produce gastrin. Gastrin stimulates parietal cells to release acid. You get way too much acid production. And people with HP infections have stomach upset. Why? Not because it causes ulcers or anything like that. because you way overproduce acid, and it can burn the stomach, and it can burn the esophagus, and it can burn the duodenum. We'll get to that, though. And then, yeah, I think I said that already. All right, so here's bullous pemphigoid. This is, actually, it's a mild case of it, but you can see the little, it's a blistering disease. You see the little random blisters all over the place, and you can see he's pretty erythemic and scarred up. There's just like a scar there. So you keep going through cycles of these, and they can go into remission, but we'll talk about this. I think I put these slides back in 7th quarter. Pemphigus vulgaris I took out, though. It's even more rare, but that's a deadly one. Causes of GERD-like symptoms. So some more causes. Well, what if you got a costochondral problem? You got a rib out of place right at the sternum, or at the costal cartilage of the sternum. What if there's a rib out of place there? That can cause GERD-like symptoms. What if you have pneumonia and it's inflamed the pleura, and you have pleurisy? That can, pleuritic chest pain is different. You can tell that apart. Did we talk about that? Or you get that stabbing pain? I think we did. It's another cause. Pneumonia is a cause of pleuritic chest pain as well. But it can, early on, it can present like GERD as well. The gastropathies, the atrophic, the non-atrophic gastritis we'll look at, they can do it. PUD, peptic ulcer disease, which is it's an ulcer in the stomach, or usually the duodenum. That can certainly cause GERD-like symptoms. Maybe you have a hypersensitive esophagus, and everybody gets a little acid up there. Some people, it doesn't bother them. If you're hypersensitive, it bothers you really easily. And some people with depression and rumination, people who focus and they get depressed, and anxiety's probably in there as well with these things. And they focus on their pain, and they're depressed, and I hurt. So it's stomach upset is very commonly associated with depression. There's a lot of research on that. Same with anxiety. So if you fail PPIs, what do you do next? So you failed everything: prokinetics, H2 blockers. You've been good. You've been trying to follow the right is wrong recommendation, and you're just miserable. You have GERD almost every day. What do you do? All that acid bathing of the esophagus is not just about pain and discomfort. You could get a Barrett's esophagus from that, which we will talk about. But the gold standard treatment is something called the fundoplication. And it's a big surgery, but it's got decent results. So make sure your patient is really disabled. This is not something that they get heartburn a couple times a month. You don't go for a fundoplication. This is a weekly problem you struggle with, because things can go wrong with it. But it's a surgical procedure, and it fixes the lower, or tries to fix the lower esophageal sphincter by beefing it up, by wrapping, believe it or not, by stretching and wrapping the fundus of the stomach around the abdominal esophagus. Yeah, is that crazy? But yeah, they can do that. And yeah, so they loosen the stomach up from its connections, and they make sure the fundus is loose, and they wrap it around the esophagus and sew the two ends together. Let's look at a picture. And all the moorings are gone, all the ligaments that hold it there. It's a really basic cartoon, but they wrap it around like that, and they sew it, and it'll scar shut right here. And that's a fundoplication. They also go up here to the esophageal hiatus, and they maybe put a couple stitches and try to tighten this up as well, to try to beef up this lower esophageal sphincter. So you basically made a new lower esophageal sphincter, and you have your wimpy one up here, which they try to reinforce by tightening up that esophageal hiatus. Goals of the fundoplication, what are they? To fortify the lower esophageal sphincter. That increases the closing power, so reflux can't go up there if that's got more beef to it, more tone to it. If there's a hiatal hernia, they can repair that while they're in there. They also tighten the esophageal hiatus and tighten the right crust as well to try to add some power. So the obvious complication with this is esophageal stenosis, right? What if they get it too tight? So that's a problem. So a good chunk of these people, they do battle with some dysphagia. They trade the GERD for dysphagia, which in a way is better because it's not good to have acid constantly bathing your esophagus. The tissue will morph into a new tissue and it can become precancerous. So yeah, so most people, I guess I took the stats out. I thought I left that in. But most people are pretty happy with the procedure. All right, so we've been talking about this Barrett's esophagus. Let's really get down to this thing now. So let's review a little bit of pathology, like Cooperstein pathology. So way back, first quarter, from Rubens and Robbins, let's talk about tissue change. So hyperplasia, what is that? That is perfect example is a callus that you build up from in your new shoes. Or if you're playing the guitar, you build up calluses on the tips of your fingers. So that's the cell's response to chronic stress. And it does so by there's no mutations involved. It just the process of mitosis is speeded up by the stress. And therefore you build more cells than you're supposed to have on the area of stress. And it's really as simple as that. Take the stress away, and the calluses go away, and so does the hyperplasia. It's not a permanent type of thing. Now, metaplasia, this is that same chronic stress, and maybe the hyperplasia starts, and if the stress is severe enough, you may go to this phase. Now we're heading down the road of cancer. So metaplasia means that the cell tissue type has actually mutated, changed into a new tissue type. So in the case of our esophagus, we have a squamous epithelium in there, 3 layer? It's a little shorter than normal, but that changes into a columnar. This columnar of the intestine, the stomach, is thought to be better able to stand acid. Right? So that's one example. But metaplasia means the chronic stress of the native tissue changes into something more rugged or something that's better able to stand the new environment. And when this is seen by the pathologist, you have yourself metaplasia. Okay, metaplasia usually involves simple columnar morphing into a stratified squamous, like down in the cervix, things like that, places like that. Classic, what can cause the stress? What stresses out tissue to the point it has to change into something new? Cigarette smoke particles are notorious for doing this in your lungs. We'll look at that more specifically. Pollution, just like cigarette smoke particles. Aspirin and NSAIDs can cause metaplasia of the tissues of the esophagus and the stomach and the intestine. And then HPV virus down in the cervix, you're infected with that. That's a constant irritant of the cervical tissue, and that can morph into a metaplastic tissue. And if the virus is raging still, it can become dysplastic and go right into cancer. All right, smoking effect in the esophagus. We got to mention this, right? So smoking. Now, some people's esophaguses are tough as nails, and the smoke doesn't seem to bother them. Or same with not with esophagus, with the trachea and the tracheobronchial tree. But normally that should be tracheobronchial tree up there, not the esophagus. Doesn't have much effect. Maybe on in the mouth though, the oropharynx and the laryngopharynx, it might have some effect. But let me make a note here to change that. Let's slide 243. Change. So with chronicity of smoking, so the tissue, the native tissue of the tracheobronchial tree, which is non-ciliated, or which is the native tissue, is pseudostratified, ciliated columnar epithelium. All right, those are really important. Those little types of cells, right? So it's columnar. Remember, they're all funky looking, but they have these hairs up there called cilia, and they beat and they sweep bugs. The mucus layer, we'll look at a picture in a minute. But remember, these guys are like really weird in shape. It looks like they're multi-layered, but they're really not, because they all go and attach to the basement membrane, right? So these are all, yeah, but they all have cilia growing out of them, right? So that pseudostratified, meaning fakely stratified ciliate columnar epithelium. Some people with cigarette smoke, this tissue can't stand it. And it says, we can't stand it, we're getting inflamed too much, we need to morph into a new tissue. And you get what's called a squamous metaplasia of pseudostratified ciliated columnar epithelium, and it turns into a non-ciliated, stratified, simple squamous, which is multi-layered, and it's better to handle and deal with that cigarette smoke. So great, you can deal with cigarette smoke, but what about your cilia? This is non-ciliated. There goes your tracheobronchial, or your escalator. There goes your way to sweep dust and gunk out of your lungs, out of your tracheobronchial tree. So without the cilia, tracheobronchial tree has no mucus escalator. So you can't sweep bugs out anymore, right? The broken escalator leads to that. How do you get gunk out of your lungs, especially in the morning? How do smokers wake up? The cilia hasn't swept all that gunk up into the larynx like most of us has. Most of us, we wake up and we cough a little bit and we spit it out. But these guys, it's still stuck in the tracheobronchial tree, so they have to hack and cough for minutes, sometimes hours. They cough until they kind of free that stuff up. It results in, Rubin says, impaired ciliary clearance. So that's, if I can see that word showing up on boards, impaired ciliary clearance. That's one of the effects of tissue metaplasia from smoking. In other words, you screwed up the cilia, you can't sweep the gunk out of your lungs anymore. Mucus production can also be down, so the mucus that is produced might be too sticky, and it paralyzes almost like what's that disease that slipped my mind? But anyway, so here's the pseudostratified ciliated columnar epithelium of a normal person. And say this is your right main stem bronchi or your lobular bronchi or anywhere in the tracheobronchial tree that has cilia, your trachea. And you have two layers. You have mucus glands, which aren't shown, but you secrete two types of mucus, remember, from your histology. There's a gel layer on the top, which is like fly paper. It catches these bugs. There's the little bugs, and it catches dust and pollen and crud. And then if this thick layer was all the way down here, cystic fibrosis is what I was thinking of. Cystic fibrosis, this thick layer goes all the way down. Great at catching bugs, but it can't go anywhere. You have to have a sol layer. Like, what about Sol? Watching that, that's a great show. Anyway, there's a sol layer or thick layer down here, or thin layer, sorry. And it's thick enough to support and attach to the thick gel layer. So it connects to this, but it's thin enough to allow the cilia to still beat. So you can move this whole thing. You can move it out toward the larynx up here, which is the job. And then once it's in the larynx, you get that sense to cough, and you can cough it up and spit it out, or you can cough it up and swallow it down the esophagus. So whatever you want to do, but that's an important thing. So smokers who have metaplasia, they don't have that anymore. Here's an example of there's normal pseudostratified ciliated columnar epithelial, and then all of a sudden, from all the smoking, this tissue says, forget it, we're not going to be all beat up anymore, and it's become metaplastic. There's no more columnar cells, and it's all a stratified squamous. But there's no cilia. That's the problem. There's no cilia. Okay, further tissue change. What about beyond metaplasia? Can you get worse than metaplasia? Of course you can. With continued smoking and irritation, the metaplastic tissue may start getting inflamed and getting irritated to the point where you start, and you can't change into another type of tissue. There's no other tissue to change into. But the problem with the chronic irritation is now you're going to start getting some DNA damage, and you're going to start getting some mutations happening in cells, and then the tissue's going to start looking funky. So once the cells start become funky looking, like their nucleus is too big, they're too round. If it's squamous tissue, it's no. Remember how squamous tissue starts out in the bottom as almost cuboidal or columnar, the basal cells, and then you go up to the spiny layer, and they start getting more spiny looking, and granulosa layer start getting a little more flat looking. But you get to the corneal layer, they're flat, right? They're dead cells filled with keratin. So in someone with dysplasia, you'll see maybe this weird shaped cell here and another one here, and maybe there's a flat one here and there's another one here. So it's all messed up, and you can have all these mutated cells growing. And some of the mutations aren't conducive to the environment and they die, but some of the mutations may be conducive to the environment and they perpetuate. And that's what dysplasia is. Let's see. So with everything I said, continued smoking and irritation, the chromosomal damage occurs, and the damage causes a precancerous condition called dysplasia. And some of these cells of metaplastic tissue will develop mutations. The mutations start to grow rapidly. These cells, if they're more successful, if the mutation is a mutation that makes the cell more successful in its environment, they proliferate. And as the dysplasia gets worse, more and more cells start to become immortal. You start turning off, the mutations can start turning off the apoptotic mechanisms. Remember, normal cells aren't around super long time, they die. So you don't get an accumulation of cells, but these dysplastic mutated cells, they are immortal because that mechanism, the mutation has turned off that mechanism. And you can start building up a bundle of those cells, and that's called a tumor. Right? So cells don't die like they're supposed to. They live forever. It causes the cell population to accumulate, and you get a tumor formation. And then you usually go through this low grade to high grade. Low grade dysplasia typically is still attached to a basement membrane. It hasn't went into the deeper tissue yet. Definitely any dysplasia is a precancerous condition. Some authors consider metaplasia a precancerous condition. But yeah, if you have a dysplastic tissue, they need to take that thing out because it is considered precancerous. But it doesn't involve the whole tissue yet. And if you remove the irritant, you stop the smoking, even with some cases of dysplasia, it can fix the problem. Still not late to fix it. It's not always true, but most of the time it's still true. By the time it gets to high-grade dysplasia, the immortal cells have really taken over the tissue, and the tissue doesn't look normal anymore. Can't recognize normal cells. The basement membrane is still holding. Here's the difference between cancer and high-grade dysplasia. High-grade dysplasia hasn't breached the basement membrane. But once you got cells going through the basement membrane into the deeper tissue, now you have yourself cancer. Some authors actually call a high-grade dysplasia, they call it cancer in situ because it hasn't pierced, but it's pretty darn close to piercing the basement membrane and getting into the blood vessels below. Can I grow that? Let me see if I can draw this. So these are all cancerous cells hanging out, and they've grown into a tumor up here. Great. Here's the basement membrane. Okay, so that's an epithelial layer. Underneath the epithelial layer, you do have blood vessels, and you have lymph system under here, right? So if all the cells, if you can't recognize any more cells, you got yourself a high-grade dysplasia. But once these cells start ripping their way through the basement membrane, and they start showing up down here, you got cancer now. And different cancers have different ability. Once they're loose from that basement membrane, they can crawl. And some of them can jump right in the bloodstream. Some of them like to go, let's see, what other colors do I have? Pink. Let's say here's the lymph vessels. Some of these guys like to go jump into the lymph vessel. And now you're in trouble, right? Because the lymph vessel will go up to, let's say, a lymph node here. And the cancer cells will they'll go through the lymph system. Right? They'll start to swell up this lymph node. They'll become inflamed. But if they keep going, I won't changing colors too hard, but they can take off and get into the general circulation, and they can go anywhere. They can go to the brain, the little toe. They can go to the lungs. So that's kind of the deal of cancer. But most authors say to be cancer, you have to penetrate. These cells have to penetrate the basement membrane, and then they're loose. Right? So that's my little spiel on that. And cancer, the severely dysplastic cells break the basement membrane. Cancer is declared. Now, everything I said, now they can spread into deeper tissue. And they can spread to other locations, and that's not a good thing. All right, drink of water time. Just observe this. Why do I have Dr. Jekyll and Mr. Hyde up there? Well, because the stratified squamous of the esophagus is going to morph into a single layer, simple columnar epithelium. And that's what a Barrett's esophagus is. It's an acquired metaplastic, dysplastic condition. You won't know for sure until the pathologist writes his report. But the native tissue ain't there anymore because of chronic GERD. It's got nothing to do with smoking. Because of chronic acid reflux, you now got yourself a precancerous condition. Esophageal cancer is horrible prognosis. I think the 5-year survival, if I remember, is about 17%. So that is not good. What is that, 83%? Is that right? Die in 5 years. That's with treatment. Without treatment, you don't have a chance. All right, so Barrett's esophagus is no joke. Very high on boards, medical school, chiro, physical therapy. Everybody will test you on Barrett's esophagus. So it's a chronic. What's the cause? It's acid reflux. It's GERD. It's a chronic bathing of the distal esophagus with pepsin and acid, hydrochloric acid, and this exposure damages the native tissue to the point where metaplasia occurs. And now we're experts in metaplasia, and it might go further. Might go to dysplasia. Depends what stage it's in. Metaplasia, it's typically with Barrett's esophagus, if it becomes metaplastic, they call it precancerous. And I don't know why that is, because technically metaplasia is not precancerous in other places in the body, but they do consider it precancerous in the esophagus. So metaplasia equals Barrett's esophagus, which is a precancerous condition. What allows for the reflux? We're experts on this. A loose lower esophageal sphincter. And with or without hypoactive peristalsis. Watch out for my tests. I could change that to hyperactive peristalsis. Well, hyperactive peristalsis would be great for GERD patients because it'd sweep that acid right out of there. So be careful with that. With or without hiatal hernia is a risk factor. We'll talk about those. I have a YouTube video on those things as well. Canadian boards, I've heard rumors that they're hit pretty hard in Canadian boards. Anyway, the condition tends to oversecrete acid. So what allows for the reflux? Well, if your sphincter is shot, just a normal amount of acid secretion is going to get you. What if you have a normal sphincter, but you just make way too much acid? Well, that's Zollinger-Ellison syndrome. And yeah, genetics. Some people get stressed and they overproduce acid. People with atrophic gastritis or HP gastritis is an AK. They get an oversecretion of acid. I could go on and on listing those things. But yeah, any condition that causes that increases the risk for Barrett's esophagus. Symptoms, we know, chronic heartburn, right? Some people have stomach up. The pain is down by their xiphoid process. That's called dyspepsia. Other people might not have any symptoms at all. Those people are at more risk because if they don't feel the damage being done, they could end up getting dysplasia and could morph into that deadly cancer. All right, how do you make the diagnosis? There's 3 things that need to be done. So endoscopic evaluation, right? So you have to have endoscopy to make this diagnosis. And then you have to have histological sampling based on that examination. And then you have to have analysis of that sampling to make the diagnosis. So we've looked at this before, but there's a nice looking lower esophageal sphincter. We're looking down through an endoscope inside the distal esophagus, and we can see there's the gastric folds there, so we know this is lower esophageal sphincter. The Z line, which is the meeting of the esophageal stratified squamous tissue with the simple columnar tissue of the stomach, makes the Z line here. And it's never really looks like much of a Z to me. Bottom line, it should be at the level of the lower esophageal sphincter. Is that normal? Well, I drink some water. Yeah, that's right where it's supposed to be. So great. How about the next picture? Well, one more picture over this, but now let's look at how you make the diagnosis by endoscopy of Barrett's esophagus. And I think we've even talked about this before. Here's where we were, way down here where the esophageal folds are. So if the stomach tissue, if the Z line is way above the lower esophageal sphincter, you got yourself a Barrett's esophagus. It's as simple as that. So you got to confirm it with a histological sampling. But really, that's about all you need to do. And then you can go a step further. 3 centimeter rule. So if the Z line is 3 centimeters, here's 3 centimeters from the lower esophageal sphincter. If the Z line is under 3 centimeters like this is, that's called a short segment Barrett's esophagus. Still precancerous, but it's not as worrisome compared to a long segment Barrett's esophagus. And that means that the Z line is more than 3 centimeters above the lower esophageal sphincter. So that's got a much greater chance of morphing into cancer than short Barrett's esophagus, even though they're both worrisome. Okay, what do you think of this? I guess I gave it away, didn't I? There's the lower esophageal sphincter way, way down there. You can barely even see the fold starting. See them way down there? They're way down here. And look at this. This is all columnar tissue, simple columnar, and this is the normal pink tissue, stratified squamous of the esophagus. And this is the Z line, which again doesn't look like a Z. But this is a long segment Barrett's esophagus. This is miles, probably 7-8 centimeters from the lower esophageal sphincter. So high chance of developing into cancer if it hasn't already. Okay, and then there must be histological evidence, so you need to find out if that, just by the looks of it, you can tell it's columnar, but it has to be intestinalized, because maybe it's columnar, but it's stomach columnar tissue. Maybe it's cardiac, from the cardiac region of the stomach, or maybe it's from the fundic region of the stomach, or maybe it's from the pyloric region of the stomach. That doesn't count as Barrett's esophagus. It has to be columnar tissue with goblet cells, which come from the esophagus, or which come from the intestine. So that has to be intestinalized. So this stuff, when they do histological sample of this, it has to look like duodenal tissue, where it has columnar cells, simple columnar cells, and it has goblet cells. Stomach doesn't have goblet cells, but the intestine does have goblet cells. So that's how you can tell. So specifically, there has to be at least intestinal type columnar epithelium, intestinal, with their goblet cells. Got it? Other types of metaplasia, as I just said, so there's 2 other types of metaplasia. It could be cardiac type columnar metaplasia or fundic type columnar metaplasia, or even pyloric. I didn't put it in there, but pyloric type columnar metaplasia. Those don't count to making the diagnosis of Barrett's esophagus. It has to be intestinalized. Right, here's a beautiful stratified squamous, non-keratinized, but there's those top granular layers, and you can see there's stratum basale down here, and there's the spiny layer, granulosa layers here. Everybody looks happy. And then look at this mess. You got all these weird glands. What the heck are all these things? Those are all goblet cells. And then, I mean, this is the submucosal layer underneath here. So where's this thick layer? It's gone. It's intestinalized now with goblet cells. And yeah, so that's no good. Bad sign, if metaplasia morphs into dysplasia, that's not good. Then there's an extra high risk for the development of esophageal cancer. 40-fold risk, really bad sign. If you're monitoring through frequent endoscopy, if you're monitoring your Barrett's esophagus, and it's right now, it's still considered metaplastic tissue. If it turns into dysplastic, which is like a precancer, metaplasia you consider a precancer. If it turns into dysplasia, which is a precancer, your chances for keeping right on going into full-blown cancer, which penetrates the basement membrane, 40-fold increase. So that's really a bad sign. It has to be watched like a hawk. There's another long segment, Barrett's esophagus, and when they did the histological analysis, it actually had penetrated the basement membrane and was diagnosed as cancer in situ. What's the epidemiology of this stuff? So age-wise, it's a middle-age and older adult disease. It's not seen in children, really rare in children. The average age of diagnosis is about 55. Caucasians tend to be more affected. Black people and Asian people, they're not as affected as much for genetic reasons. What's the prevalence? So population prevalence is difficult to assess because many patients with Barrett's esophagus have no clue that they have it, and that's the scary thing. The classic study, the REC study, took almost 1,000 patients who were asymptomatic. I'm sorry, they weren't asymptomatic. They were symptomatic with GERD-like symptoms. Let me write that slide down, 2666. So they did have GERD, so just a routine endoscopy. And surprisingly, almost 7% of them had a Barrett's esophagus. So, yeah, it's like a serious problem out there. And you never hear of this thing either. You guys probably never heard of a Barrett's esophagus. Although I guess I told you about it. If I had you for anatomy, I can't remember if I did or not. Anyway, some studies it's 15%. Some of these things maybe not quite as well done as that study, but yeah, it's a big problem. The chances for Barrett's esophagus becoming cancerous has increased more than 7-fold, and we don't know what that's about. We have a couple theories. How come nowadays Barrett's esophagus is getting more and more and more prevalent over the past 2 decades? Well, one is we've learned about H. pylori, and we're killing it with antibiotics, which is great because there goes the extra acid. Remember I said HP stimulates the production of gastrin, and we'll talk about that when the time comes, but it makes tons of extra acid. Extra acids greatly increases the chance of getting GERD. You have increased GERD, you have increased Barrett's esophagus. Another one is obesity. The world is getting fatter. America's getting fatter. And that's increasing your intra-abdominal pressure, and that's squeezing the acid, encouraging the acid to, especially at night, to go up into the esophagus. So that's another thing that's causing Barrett's esophagus. What are the risk factors for Barrett's esophagus from just GERD turning into Barrett's esophagus? Long history of GERD. You fought GERD for many, many years. If you have a large hiatal hernia, you're going to have GERD whether you know it or not. So that's a risk factor. If you do mammometry and you have lower esophageal or decreased lower esophageal pressure, that can do the trick. If you have decreased esophageal motility, peristalsis on mammography, that can do the trick. Why would that one do the trick again? Decreased motility, decreased peristalsis. Good. In that little picture I drew, you can't sweep if you do burp up a little acid, if you have good motility, secondary peristalsis will sweep it out, dump it in the stomach. But if your peristalsis doesn't work good, it sits there and burns and causes metaplasia. People with decreased sensitivity to acid, that's a risk factor because they don't know that their esophagus. I mean, some of you out there maybe don't. You have decreased sensitivity. You just don't have a lot of nerves to feel esophageal pain. And maybe some of you out there are getting esophageal damage and don't even know. So everybody should have endoscopy done at between 40 and 50. And then obesity, again, is a risk factor because of the increased intra-abdominal pressure. And we talked about that. Obesity increases the intra-abdominal pressure, and that pushing force, the positive force there, and you have negative intrathoracic pressure. It encourages gastric acid to move upward. Okay, central obesity is also the worst. The Homer Simpson belly is the worst. It's more than if you get fat deposits on your rear end. That's not as much of a risk factor. What about Barrett's esophagus versus PPIs? About 30% of Barrett's esophagus do get good relief. That's not a huge number. Symptomatic relief. But here's the thing. This 30% is special 30%. They still, even though they're having good relief, they're still getting acid reflux, and they're still having an increased chance for developing carcinoma. So, therefore, even these asymptomatic patients have to be watched. I mean, if you have a Barrett's esophagus, you and your gastroenterologist are going to get to know each other because you're going to have to be monitored and have repeated endoscopic evaluations just to see how that tissue is doing. What's the management of this thing? Kind of controversial how to manage Barrett's esophagus, but definitely need to shut off the acid. Even if you're not having symptoms, you're going to be on proton pump inhibitors for life. And you need regular endoscopic evaluations and reevaluations. If you just have metaplasia once a month or once every 2 years, you should have a redo. I've heard some enterologists say once every 3 years. Certainly no more than 3 years. If you have low-grade dysplasia, every 6 months, you have to go back in and get it. And this test is not a heck of a lot of fun. Not to mention, you better have insurance. And if it's high-grade dysplasia, about every 3 months, you're going to need to come back in and get that thing checked because it can grow really fast. We were talking about esophageal carcinoma. I've kind of been alluding to this. It's a very dangerous form of cancer, very bad prognosis. With treatment, 5-year survival rate is 17%. One of the worst ones there is. 2005, it killed more than 400,000 people worldwide. And it's the 8th most common cause of death worldwide to date. 16,000 new cases each year in the United States. And in some countries, it is the most common upper gastrointestinal tumor that there is. So it's definitely around. The signs and symptoms are solid food dysphagia, which progresses to a soft food dysplasia, and then the liquid food dysplasia. What in the heck does that mean? Well, that means that the person starts out and they have trouble eating the food. It hurts. And they get dysphagia and it burns when it goes down. And so instead of go to the doctor, what do? They start eating soup. So soft foods and eggs and things like that go down easy. But another 6 months goes by and now they're having trouble with the eggs going down. And then instead of going to the doctor, they said, well, I'll just eat soup, liquid diet only. So I shouldn't have said soup. For soft food dysphagia is like noodles and food that breads, lots of breads, not meat and things that are hard to chew. But then eventually the liquid diet starts hurting as well. And it's probably, if they haven't went to the doc by then and got scoped, it's probably too late. but then they'll start getting intentional weight loss. If you go to just a soft food diet, or especially a liquid diet, you're going to lose weight like crazy. Signs and symptoms may or may not be associated with GERD, as we said. In fact, 45% of patients with esophageal adenocarcinoma have no or very frequent GERD. In the later stages of the disease, you could get supraclavicular lymph node enlargement, lymphadenopathy, right greater than left. You can still get it Virchow's node, but more likely it'll be on the right side first because of the way the lymph nodes are situated around the esophagus. And yeah, so there could be a Trousseau's sign there. So here's a Trousseau's sign. This is probably a gastric carcinoma, I think, but just to show you, waited way too long. So making the diagnosis, endoscopic tissue biopsy needs to be done. And CT scan is ordered to rule out metastatic disease to spreads. Better to get a PET scan if that's available. It has much greater sensitivity. It's more expensive too, and not as many centers have it, but it's much more sensitive. And then you'll do lymph node biopsies of the sentinel nodes and anything else where it shows up. You have to go inside. The celiac nodes are often biopsied as well. Okay, here is a PET scan that was ordered on a 55-year-old male, smoker, long history of GERD. And yeah, there we go. So this all lit up here. Contrast, the tracer molecules found the cancer cells and lit up, and it's pretty widespread, which is unfortunate. Most common types, there are two common types. There are adenocarcinoma, and then there is a squamous cell carcinoma. So the adeno, this is the most common in developed nations. So in our country, if you're going to get one, it's probably going to be the adenocarcinoma. It is on the rise, though, as I mentioned. This is associated, this is the one that comes from a Barrett's esophagus. And then we have squamous cell carcinoma. That is the one that's associated with smoking and alcohol use. That's the number one of this esophageal cancer worldwide. So that's a good question. Adenocarcinoma, I always think, one of my markers are still on. I think USA adenocarcinoma is in the West. And then squamous cell is somewhere else. Or however that works for you. All right, that's the end of that gruesome topic. Let's talk about a Mallory-Weiss tear of the esophagus. So you can get a tear in the wall of the distal esophagus. And if you rip the wall of the esophagus, there's blood vessels in there, right? And so you get, it usually occurs at the gastroesophageal junction. The tear may extend into the cardia or the fundus of the stomach. Tear typically results in various degrees of bleeding, which drain into the stomach. And blood in the stomach can be very irritating to the point of making you throw up the blood. So typically caused from multiple episodes of vomiting and retching. So people who throw up a lot, some people throw up really gracefully and gently. Some people throw up very violently. And these are the ones who are at risk for ripping their esophagus, especially if they have connective tissue disease, especially if they're older. But yeah, you can rip your esophagus from throwing up. And yeah, and you can bleed from that. Hematemesis. So some of the symptoms of this are hematemesis or coffee ground vomitus or even melena. And we need to fall down a rabbit hole because I just lost you guys, right? Some of you I did. And this, of course, well, who throws up? Alcoholics, always throwing up. Bulimics are purposely full. So bulimics are at risk for Mallory-Weiss tear as well. All right, so let's fall down a little rabbit hole. Before we do that, we need to fall down a rabbit hole, look at some anatomy, bring back your gross 2 anatomy. What's the ligament of Treitz? AKA the suspensory ligament of the duodenum. What's this thing? Oh, okay. Remember the duodenal jejunal flexure, that's the end of the duodenum. We got the descending, the transverse part, the ascending, and then it curves. Right where it curves, it dives into the peritoneal cavity as well. But there's a ligament that holds this in place, and that's called the ligament of Treitz. There's actually a band going into the celiac trunk as well. Wasn't quite drawn correctly. But anyway, yeah, that's the ligament of Treitz. Who cares about that dumb thing? Well, we can use that for a kind of a dividing ground. So anything upstream from the ligament of Treitz, including the stomach and the esophagus, those are called upper GI bleeds. Upper GI bleeds. We've heard of that before, right? Upper, always got a lower GI bleed. Always got an upper GI bleed. What does that mean? It's in relation to the ligament of Treitz. So basically the duodenum, however you want to say it, the stomach and the esophagus are the cause of upper GI bleeds. Anything downstream to this, so the jejunum, the ileum, the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, even the rectum, those are all lower GI bleeds. Everybody got it? Lower GI bleeds. All right. So upper GI bleed, everything I just said. Bleeding from a source proximal to the ligament of Treitz. Lower GI bleeds distal or downstream from the ligament of Treitz. Everything I just said. So what's the deal with blood in the stomach? Blood and hydrochloric acid and some of the intestinal, the duodenal enzymes has a marked effect on blood. Specifically, it takes hemoglobin and breaks it down into a really dark colored molecule called hematin. And the hematin gives it a really dark look. So you can always tell when blood comes out either end, whether you vomit it out your mouth or you poop it out your rear end. If it's really black looking or coffee ground looking, that means that blood has been around for a while. It's probably a slow leak and it's built up. It's not gushing out, is usually the rule of thumb. Okay, so that's the deal with that. If it comes out and it's fresh red, it hasn't had a chance to be acted or digested by acids very much. Right? So let's look at some words now. Hemoptysis. So that's a coughing up of a pink frothy sputum, either with or without mucus. It means it's coming from the respiratory system. Right? So it's not going to have any food particles in it or anything like that. It might have some mucus in it, but it's going to be frothy because it's filled with alveolar air. Okay? And you usually cough this up and spit it out. You don't vomit up. Hemoptysis is the coughing up of a spit that's tinted with blood. And it can be a little blood or a lot of blood. It comes from the alveoli or small bronchioles. And what causes it? It's caused by pulmonary hypertension and pulmonary edema in the microcirculation around the alveoli. If you have a beaver dam in the heart, do I have to draw this again? Here's the heart. Let's see, where can we draw it? There's the heart right here. Okay, and here is the pulmonary vein. We'll just say this person only has one lung and one pulmonary vein. And the pulmonary vein goes into the lungs, right? And then here's an alveoli. So if we get a beaver dam in the heart, you pick the beaver dam. How about tricuspid valve stenosis, where these valves are frozen shut? So we're getting a small ejection fraction, but it's a beaver dam right here. You can't get blood in. So what happens to the blood? A little bit of it gets in and gets out of the heart, but a lot of it backs up, right? Backs up into the lungs like a beaver dam would. And we get all this gunk in here, and the pressure raises. Remember, we got this side of the heart is pumping blood into the lung, and it keeps pumping. So the blood is going to start building the pressure up in here. And that pressure is going to force some of the blood into the alveoli, and you're going to cough it up. It's going to go through the tracheobronchial tree, and you're going to cough it up. And that's exactly where that comes from, because of all this pressure here. And it could be a failing heart. It could be aortic stenosis. It could be any beaver dam in the heart can cause a pink, frothy sputum. Everybody good with that? Good. Hematemesis. So what does that word mean? Hematemesis or vomitus. That gives it away. They're not going to say vomitus. They have to say hematemesis. But I mean, there's the emetus. It's throwing up right there. So it's the throwing up of blood. So now you're not spitting up blood coming from the pulmonary system. Now you're vomiting blood, and that's coming out of the stomach and out of the esophagus. So what does it indicate? It indicates an upper GI bleed. So it can only come from either the esophagus, the stomach, or the duodenum. Got it? Hematemesis only from the upper GI, or it's only from the the stomach, the duodenum, or the esophagus. Right? Now, it could be two colors. If the blood is gushing out, let's say you got an ulcer in your stomach and it's gushing blood in the stomach, you're going to throw up bright red blood or just a red blood. And that indicates the bleed. Or maybe it's in the duodenum and it's so irritative it can go right back through the pyloric sphincter and get into the stomach real easily if you're bleeding a lot. You'll probably have some going out the other end as well. And that might be melanic stool, because if it goes downstream, it takes a long time to process. But some of it's going to go upstream into the stomach. You've got to throw it up. And if it's bright red, you're quite worried. I mean, any blood you're worried. If it's been in the stomach for a long time, and maybe it's esophagus, maybe you got esophageal ulcer, you got GERD, and it's leaking blood, and the blood is drizzling down, building up slowly in the stomach, and then you throw up. It's going to be this classic coffee ground vomitus. Coffee ground vomitus. So it's going to look like, or hematemesis, coffee ground hematemesis. They usually call it vomitus with coffee grounds. Nevertheless, it's not going to be, it's going to be digested. So here's hematemesis of a bright red blood that's come out. Okay, and there's coffee ground vomitus. Again, it's caused from the hydrochloric acid and pepsin breaking down hemoglobin to hematin. And there's somebody who threw up coffee ground vomitus. And it literally looks like coffee grounds, right? I would say. Okay. Now, hematochezia is another one. Hematochezia. That's the passage of fresh red blood through the anus. So you're pooping it out. And it's red. So this is going to indicate a lower GI bleed. Usually, most common cause is from a colonic diverticulum. Remember, a diverticulum. So here's the descending colon. There's that crazy sigmoid colon. A diverticulum is an outpouching. It's just like an appendix is a diverticulum. It's an outpouching of a tube. And I can't erase that, but I could erase that because there's a lumen right in here. And yeah, that thing can get infected and bleed, and you can start bleeding from one of those things. Okay. So yeah, we got our woodworking neighbors going off again. I wish he'd shut his garage door. Anyway, sorry about that. Passage of fresh blood through the anus with or without stool. Hematochezia indicates a lower GI bleed, most likely from colonic diverticulosis. As we said, differential diagnosis is from hemorrhoids, inflammatory bowel disease. Hemorrhoids are probably the most common benign type of cause of this thing. Maybe you have a tear. Maybe you had a big piece of fecal material go through there and you ripped your anus. You can bleed from that as well. That can happen. So if you have a really aggressive upper GI bleed, I mean, so much blood could pass through the intestines, and maybe not a lot of it gets absorbed. So that's a possibility. Okay, there's a little baby hematochezia, nice red right there. So not a good sign. Melena. So that results. We talked about that, didn't we? That's the tarry-looking stool. Did we talk about that? Results from an upper GI bleed or proximal lower GI bleed. Blood is very digested by the time it gets down there, and you get a black tarry-looking stool. It's foul-smelling. You can usually smell it with your eyes closed. You can tell something's wrong. And again, it's from hemoglobin being transformed into hematine, and it really gets processed because it goes for a long ways. There is your run-of-the-mill tarry-looking melenic stool from an upper GI bleed. One more definition. So chronic occult intestinal bleeding. You might have really slow bleeds from intestinal cancer or colonic cancer or Crohn's disease that you don't even know what's there. You don't see it when you wipe yourself after a bowel movement. And so there are these fecal occult blood tests that you have to do. And yeah, they're really, I mean, they could save your life. They indicate a bleed. And it's just a little, you take a stool sample and you put it in this chemical and send it into a lab, and they analyze it for occult blood. What are the risk factors for Mallory-Weiss tear? We're out of the rabbit hole. So anything that makes you throw up. So alcohol overconsumption, probably the number one factor. Alcohol not only weakens your lower esophageal sphincter, so you could get some acid coming in there as well. But it makes you throw up. I mean, alcoholics, they drink so much they throw up, and you keep throwing up all the time. And stomach acid is going to go all the way up your esophagus when you do that. Bulimics throw up on purpose, right? They eat a big meal and they throw up because they feel guilty. Anticoagulation therapy makes people's very susceptible to bleeding. You bleed much more easily than maybe another person would have coagulated that big piece of pork that you swallowed, but you, or I don't know how to say that. If you're anticoagulation, you're just more delicate and you could bleed from the pressures of throwing up. Hiatal hernia, that can also cause GERD, which weakens the esophageal lining, makes it susceptible, so you throw up with that. And you could bleed from that. And then some people, there's none of these risk factors. They just end up with a bleed. What about Mallory-Weiss tear? Can you get peritonitis from a Mallory-Weiss tear? Yeah, you can. Remember, the abdominal esophagus is an intraperitoneal organ. So sure, if you burn a hole through it, you can definitely get it. Mallory-Weiss tear. There's another picture of it. Mallory-Weiss tear. 10% of people with hematemesis end up having a Mallory. So if you come into the emergency room and you're throwing up either coffee ground or just bright red blood, 10% of these people end up having a Mallory-Weiss tear was the cause of that. And the mortality rate is 3% with treatment. So that's, I mean, this is dangerous when you're throwing up blood. All right, some people, you're bleeding a lot. If it's really bad bleed, you slip into hypovolemic shock and pass away from that. Esophageal varicosities. Seems like we've been doing this forever, but I did want to get through a little bit more this time. So esophageal varicosities, varicose veins also or may also occur in vivo inside the body. So in the case of esophageal lumen, or in this case, so varicosities, esophageal varicosities are simply varicose veins that can be on top, outside of the esophagus, or they could be interluminal varicose veins. Either one of them are deadly. They tend to be more inside the lumen, though, and they tend to be in the distal esophagus. They're typically associated with liver disease. In fact, that's the only thing I can think of, unless you have a tumor. They're caused by an increase in portal hypertension. It's caused by portal hypertension. So the hepatic portal vein can't get blood through the liver, and it backs up. And we studied that in Gross 1. We know the hepatic portal splits into the splenic vein, the superior mesenteric vein, but there is a tributary off there, up higher, we'll look at in a second, that goes to the esophagus. And so the beaver dam, the backup of fluid, will go all the way into that. Prevalence of liver disease is about 0.07% of the population, about 50%. If you have liver disease, it's super common to get these esophageal varicosities. Because if you get liver disease, the liver's like a beaver dam, and the vena cava and the portal vein, it can't get blood through. So you get kind of a double backup from that. What's the sequelae of esophageal varicosities? Well, you can die. You can bleed out from this thing. Why? Because hemorrhage is often severe. On average, there is a 20% mortality rate. That's not 2%. That's not a mistake. 20% mortality rate for a first bleed. So that's like, what, 1 in 5? This is like no joke. So people with liver disease and the hepatitis, they have to be careful with things like this. And there may be no symptoms, is the kind of scary thing. The first symptoms may be throwing up blood if it's an internal bleed. Okay. If the varicosity is really large, or a lot of these people are on anticoagulants for other problems, the mortality rates can go up around 50%. So not a good thing. Here's a normal esophagus. We're good at looking at those. What do you think of that? I haven't seen a picture like that before. We're up way higher than the Z-line. Yeah, those are no good. Those are varicose veins, right? These are look at that thing. This thing's it's like probably 20 times bigger than it's supposed to be. There's another one there. If the pressure gets too big on these things, you just spring a leak. Boom, spring a leak and you start bleeding like crazy. That blood's going to go down in the stomach and start piling up. And pretty soon it's going to make you throw up, because blood is it causes nausea. But yeah, that's basically the deal with those. And there's one method, if this one was bleeding, so they're able to bunch it up and put a band around it. Same thing they do with hemorrhoids, to try to let the body kind of weld it shut with fibroblasts. All right, etiology, again, portal hypertension is the number one cause, secondary to cirrhosis of the liver. What causes cirrhosis of the liver? Well, alcoholism, probably the number one cause. If you're not an alcoholic, then viral diseases such as hepatitis C and hepatitis B are notorious for doing this. Portal hypertension occurs in 90% of patients with cirrhosis, so it's even more common. Didn't I say 50% somewhere? But my slide might have been a little different. Put a note on that too to look for that. That's slide 309. 50% or 90%? Okay. Oh, there's the beaver. So we got a beaver in the liver, and there's the hepatic portal vein going through the liver to process this blood. Splenic vein from the spleen, superior mesenteric. Inferior, all the blood, all the food from the intestines is coming in here. But you got a beaver in here, so now we're getting a backup into all these areas. But there's another left gastric vein, and then there's a portal esophageal, portal vein. No, that's right, portal esophageal vein, which goes up and down the esophagus. But other causes of portal hypertension. You could, not so much in this country, but you could get bugs inside the liver. Schistosomiasis comes to mind. That could cause a beaver dam, and you could die not from the liver, but because of a bleed of the esophageal veins. Okay, neoplasm of the liver. Also makes anything that makes a beaver dam. Emboli, maybe you get a big embolism going through the portal system and it gets stuck in the liver and causes a beaver dam. That can do the same thing. Pathophysiology, blood backs up into the portal and esophageal veins. Portal veins anastomosis with the esophageal vein. And it causes those ugly stretched out veins that we saw, and they could rupture and they could bleed. Here's a little more detailed anatomy. So there's the left gastric vein, and there's the lower esophageal, kind of tributary from that, and it's meeting from the caval system, the lower esophageal esophagus tributary. And those are the ones that get all swollen up. Because, why? Because you got beaver dam here. This blood's trying to get out, can't get out. It's backing up and swelling those things up like crazy. Clinical signs of bleeding, as we said, is a couple. Maybe if it's a slow bleed, maybe it'll pass through and you get a black tarry stool called melena, melenic stool. It could, if the bleeding's severe, cause hematemesis. You could get coffee ground or bright red blood. Acute hemorrhage of these varicosity is the most common cause of death in patients with chronic portal hypertension. So it's not the ascites, it's not the swollen legs, the swollen spleen. It's a bleed around the esophagus that usually causes the death. Okay, there's the traffic jam, pretty much. There's the anastomosis between the two systems. There's the caval esophagus system, and there's the one coming from the portal vein here. And so, yeah, it just gets all swollen up like that and starts bleeding. All right, and there's a picture, a couple of these things treated and banded. And, yeah. All right, Meckel's diverticulum. We are definitely done. That's enough. I don't know how many slides it is, but it seems like we went through a lot. All right, so we got one more CVPP lecture, and I will start working on that one. See you guys soon.